Folks on the line, I'm really excited to move from Molly's tremendous keynote into our panels. The arc of our agenda today is to move through 3 different chronic care conditions. We're going to start with mental and behavioral health. We're going to go to diabetes and then cardiac care before thinking about infrastructure and then what we need to do here at the VA. I am delighted to welcome Heather Landi, Senior Editor of FierceHealthcare, and I think tenacious reporter, really pushing all of us working in the sort of digital innovation field to be better all the time, forcing the hard conversations. And Heather, I know that you will guide a tremendous discussion today as we sort of open our session from crisis to cure, improving behavioral health in the digital era. So with that, Heather, I'll hand the reins over to you, and I'm excited to learn from you and the experts you've assembled for this panel. And Heather, you get the you got it.
Okay. Thank you, Jennifer. I'm really happy to be here. I'm really excited for this panel discussion this morning. Before we start our group discussion, we're going to hear from Dr. Jennifer Ray, Supervisory Suicide Prevention Coordinator at Veterans Affairs. Dr. Ray, the audience is yours.
Thank you so much, and thanks for having me today. I'm just so excited to be here and to talk about this important topic, and super excited to see the number of attendees on the call is so impressive. So as mentioned, I supervise the local suicide prevention team here at the Ralph H. Johnson VA Medical Center in Charleston, South Carolina. And I have an interesting background that's now overlapping with my position. I previously did some research in the area of ecological momentary assessment. And in preparation for this opening today, was thinking about my days in grad school, not that long ago, but in 2008 when we were using personal digital assistants, or PDAs, to do data collection in our day-to-day work. And so we've come such a long way in a short, or such a big strides in such a short period of time. Today, I'm going to be commenting on 4 areas where I think VA has made some great strides and some new areas that are currently being developed. And so first, I'd like to talk briefly about telemental health, which really was becoming a standard part of care for behavioral health conditions before COVID. But really, COVID has pushed this into the forefront of the treatment that we're providing at VA. We know that 98% of VHA mental health providers and 99% actually in our area here are capable of doing telehealth appointments. And that was really a first step during COVID that was undertaken. We needed to make sure that all of our mental health providers could deliver this important service to increase access and make sure that behavioral health appointments were readily available to veterans during this difficult time. And we've really seen a lot of improvements to our telehealth services during COVID especially. We know that in September of 2021, over 40% of veterans who were engaged in behavioral health appointments in our catchment area engaged in telehealth visits. So that's almost half. And we know that during the pandemic, we've done so much in VHA through telehealth. We've transitioned groups, so mental health groups, to video appointments, which was a huge undertaking. Many of our VHA systems transitioned to having virtual substance abuse treatment clinics. We were able to provide neuropsychology testing through VA Video Connect, transplant evaluations, and really push the platform forward by adding things such as the white glove program, where veterans can have direct contact with someone who can help them set up a VA issued iPad so that they can successfully engage in those video appointments. We also have added VBC On Demand, which is a platform where veterans can easily connect to their video appointments on their phones or iPads or laptops at home. And so again, I feel like during the pandemic, we've really pushed telemental health to the forefront of our care in behavioral health services, making this more accessible and available to the veterans that we're serving. Area 2 is in the mobile mental health app domain. And so VA really has been pushing out a lot of treatment and self-care apps in the last few years. The National Center for PTSD has partnered with a number of organizations to develop a variety of mobile applications. And these apps are focused on common behavioral health concerns that our veterans face, including things like PTSD, depression, insomnia, alcohol use, and really general well-being. For example, an app called COVID Coach was developed during the pandemic to really help with some of those skills that veterans could engage in on a day-to-day basis for more prevention related to their mental health and behavioral health well-being. There are also apps not only for veterans and patients that we treat, but also providers, which is really, I think, a great step forward. We want to make sure that the providers who are caring for our veteran population have access to these important resources. In the past couple of years, there was a tech into care team developed at the National Center for PTSD, and they just wrapped up a 2-year QI project that had a couple of branches to what they were trying to accomplish during this short period of time. And one that was really notable in the suicide prevention world is that they were able to develop a suicide prevention or safety planning mobile app. So this was part of the PTSD Coach app. A safety plan, for those who may not know, is a life-saving intervention that has great research and evidence behind it. The safety plan can be developed with a veteran and a provider so that in the time of a crisis or during thoughts of suicide, a veteran can pull out their safety plan and actually have a step-by-step process of coping skills, to engage in, people to reach out to, where to go if they need in-person care. And this traditionally was done pencil and paper and inserted into the veteran's medical record. Now through this project, or because of this project, veterans are able to enter their safety plan into an app so that they have easy access to that safety plan during the time of a crisis. We know that I think just from anecdotally personal experience, most people are carrying their phones with them 24/7, whereas they may not have had their physical copy of their safety plan before. So this was great. As part of this QI project, staff at 18 VA medical centers were trained in how to utilize mobile mental health apps so that they could become ambassadors and really kind of spread the word amongst other staff and to train veterans on how to use the VA mobile mental health apps. We do have some research coming out telling us a little bit about how this initiative has been going. And so in a recent study in 2021, so just this past year, a study published in Psych Services did show us that at least 42% had a veteran surveyed had heard of these VA mobile mental health apps and had used at least one. And so this is definitely a step in the right direction. However, on the flip side, we know that the most common barrier to using these apps is not knowing that they exist, endorsed by more than 60% of the participants. And so continuing to get the word out is going to be a really important part of this initiative. And also currently in progress is the development of a standalone safety planning app. Some feedback that was received from veterans is that they don't have PTSD, they don't want to go into the PTSD Coach app for their safety plan. And so currently VHA is working on a standalone safety planning app that veterans could easily access on their mobile phones. The third area that I'd like to comment on is screening. Screening is really big in VA for behavioral health concerns, and on an annual basis, we're making sure to screen veterans for things like depression, PTSD, tobacco and alcohol use, suicide risk, and we do screen all veterans at least once for a history of military sexual trauma. E-screening will actually allow veterans to complete screening assessments prior to the time of the appointment that they're coming in for. And I really feel like the big advantage to this approach is that that's going to allow more time during the visit to follow up on the screens that are positive, to develop or adjust the treatment plan as the clinicians are getting real-time data coming in through these e-screening measures. This has been rolled out in a couple of VAs and piloted with, again, some published studies behind the e-screening approach. So we know from focus group data that veterans are really satisfied with e-screening, and they did over the years suggest some improvements which were taken into account during updated versions of e-screening. Probably as a lot of us would expect, we also show that millennials have higher satisfaction ratings compared with non-millennials. And so there will be some barriers to overcome in terms of full-scale implementation of e-screening. Here in Charleston, that work is underway, and we're planning soon to begin to implement e-screening so that veterans can complete these different behavioral health questionnaires in preparation for their visits and spend more time with the clinicians, again, following up on those screens that the clinicians and veterans are concerned about. And then finally, a project that I'm really excited about is a partnership between the Ralph H. Johnson VA to do a quality improvement initiative with CareCentra. This project would allow veterans who were interested in participating to download an app on their phone that would actually use artificial intelligence to deliver questionnaires to veterans when certain indicators of potential distress are triggered. So for example, if the veterans are more idle or spending more time on social media or making fewer phone calls, those types of behaviors would trigger a mood check questionnaire that would ask about how the veteran is doing, ask questions about depression, and if those are positive, additional questions would be triggered about thoughts related to suicide, or as we call it, suicidal ideation. If those questions are positive, this would allow us to quickly connect the veteran with resources, for example, local resources, including their healthcare or behavioral healthcare team, or potentially the crisis hotline when and if needed. And so we're really excited about this partnership, and we really think, again, that that goes back to the point made in the keynote speech about precision medicine. So really figuring out that point in time when the veteran needs assistance and how to connect them at that exact moment with the services that they need. So in closing, again, just really excited about what the VA has been doing, the advances that have been made in the technology realm during COVID, and these future directions that we'll be able to embark on. And we'll look forward to some more discussion during the Q&A. I'll turn it back over, Heather, to you. Thank you so much.
Thank you, Dr. Ray. And now we're going to hear from Dr. Dana Udall, Chief Clinical Officer at Ginger, an on-demand behavioral health company. Dr. Udall, the audience is yours.
Thank you so much, Heather, and great to hear, Jen, about all the good work that's already happening at the VA today. I'd like to thank the Digital Medicine Society and the VA for having me and for shining a light on this incredibly important topic of how to use innovation in order to really scale care. I'm going to talk for a few minutes about sort of the mental health landscape, what we are seeing overall. Partly because what we know is that a lot of the traditional systems and interventions that we've been using are really proving to be insufficient. So there's a lot of need for innovation right now. And I'm excited to talk about sort of what we're doing on the Ginger Now Headspace Health side of that, and then also about how the VA can really help us move forward. So we are at a really critical point. The World Health Organization estimates that close to 1 billion people globally are living with a mental disorder. So this is obviously a huge and staggering problem across all walks of life, all geographies. Sadly, we also know that about 75% of folks don't receive any treatment for their diagnoses. So another really sort of heart-wrenching fact that most people are not able to get care. And, there's a few reasons for this that I'll talk a little bit about. But, even though we're sort of seeing this global need, this burgeoning need for mental health services, we're also seeing a lot more attention being paid to mental health. So that's part of what's really interesting about this moment. But in the 25 years that I've been in the field, I've never seen so much media attention toward mental health. We are seeing in many different ways that mental health is being talked about. There's really a sea change I like to think of it as moving from margin to center, where mental health used to be so stigmatized, it wasn't really talked about very often. Now we're hearing celebrities, professional athletes, politicians, and leaders talk about their own mental health needs. So people are really coming forward and talking in a much more overt way about mental health and about the need for high quality care. At Ginger, when we look at our data, for example, and we're looking at pre-COVID to COVID, we are seeing about a 300% increase in clinical services. So that means people who are coming in and seeking therapy and psychiatry. We're seeing an even greater jump in our coaching services. So this means that when you're able to offer digital solutions to folks, there's not only a need, but there's a huge uptake. So there is really a lot more people that are actually using these systems of care on a regular basis. But we're also seeing some profound challenges that exist and that really prevent people from getting care. And some of this has been spoken to already today, but the lack of access is really very significant. We know that in 50% of US counties, there is not one mental health provider. So that means there are these sort of geographic mental health deserts where someone would have to drive many, many miles in order to seek care if there were no telehealth services available. Compounding this is the supply-demand imbalance that we talk a lot about. And what that means is that there are not enough providers to meet the need. We don't have enough therapists and psychiatrists to really see everyone. And this is part of why we need tech and innovation to really help us scale care. This becomes even more acute when we're looking at specialized populations, so non-English speakers, Spanish speakers, for example, or adolescents. It can often take months to years to get in and to see a provider. When we look at research, we actually know that it takes about 11 years on average between when symptoms start and when an individual is able to access care. Now, not only is this a disheartening statistic because we know that people need care and that they oftentimes want it, even if they're not able to access it, but it also has detrimental effects when we're looking at outcomes. So we know, and this is true for a variety of diagnoses, from substance use to depression to eating disorders, the longer it takes for someone to get into care, the worse the prognosis, the worse their outcomes. So it's really important that people are able to access care early on in their journey in order to have better outcomes, a shorter course of care, a less expensive course of care. Another thing that really impacts folks' ability to access care is stigma and confusion. And we all know about stigma. It's something that's talked about a lot. There are particular groups for whom seeking care is really quite taboo. So it's very uncomfortable to do this. And this is particularly true if services are not offered in a discreet way that is convenient and easy to access. So a lot of what we're doing at Headspace Health, for example, is really offering care through the ease of a smartphone. Sounds like a lot of this is happening at the VA already, but in a very convenient way so that there's no friction. People can really get it easily. They don't have to drive across town, sit in a crowded waiting room where they might risk seeing a neighbor or somebody that they know. It's really all from the ease of their cell phone at any moment they need it. Confusion is also a big part of this. We hear people say all the time, I don't know how to access care. I don't know whether I need a coach or a therapist or a psychiatrist. So this is a really, our system is very confusing for folks overall. Mental health is confusing. Folks don't know where to go or where to access care. So a lot of what we need to do is really make it very understandable to them too, so that they can easily reach out, get their needs met, and not have to go through that by themselves, making calls, trying to figure out the best provider for them. So a lot of what we're working on at Headspace Health is really bridging this divide. Ginger has recently merged with Headspace. We're looking to offer convenient, easily accessible care at the moment of need. One of the things we know is that activation energy takes time. So it often takes time for people to work up the energy and the courage to reach out for help. If there's not a resource available, that motivation may flag for them. They may never end up receiving care. So what we're really trying to do is to democratize mental health, make sure that everyone can get their care needs met within an affordable system that offers coaching, therapy, and psychiatry, coupled with all of the content that Headspace brings. So just to go over again briefly, the things that I think we need to do to scale care around the globe, make sure that everyone gets care, veterans as well as the general population, is make it easy to access and convenient, decrease stigma, and focus on prevention. This is really important because a lot of what we talk about in mental health is treatment. And that may mean treating somebody who has a diagnosis. In order for us to scale care, we really need to be working with folks early on, helping them with things like sleep, making sure they understand how to get good rest every night, making sure that they're exercising, making sure that they know how to manage their emotions and who to reach out to. These things will prevent those more entrenched diagnoses over time, and they introduce people to mental health care earlier in a low stigma way. Coaching is also key to this because we know that for many people, they wouldn't necessarily want to talk to a therapist or psychiatrist, but a coach feels less stigmatizing and more accessible. And finally, just want to put a plug in for technology. As I said, the supply-demand imbalance is huge. We know we can't hire our way out of this problem. So we really need to use things like AI to understand who needs care, what level of care do they need it, and when do they need it. That information helps our care teams understand very quickly who to focus on and what they need. That will help us, again, shorten the course of care and make sure folks get care in a timely way so that we can really improve access. So the last thing I just want to say is that I think that what's so exciting here is that with the size and scope of the VA and all the work that you all are already doing, you have the ability to impact veteran mental health and to really drive innovation at scale. We know that when someone has a mental health issue, it impacts them, their family, their community, and the world at large. Likewise, if we are able to provide excellent care and high quality treatment to the individual, then their families, their societies, their community, their culture is really impacted overall. So I think that's what we're really here to talk about today, is how we can drive that level of innovation and really scale care to make sure that veterans who are a vulnerable population get their needs met, and the learnings can really be translated to the greater good of the world overall. So thank you so much. I'm so glad to be here and appreciate the time.
Thank you, Dr. Udall. Now we're going to move on to what I anticipate will be a very insightful conversation about the use of digital health to address behavioral health challenges. We have a fantastic panel of speakers today representing digital health innovators, health plans, researchers, and patients. We're also going to reserve 10 minutes at the end for audience Q&A. Thanks to all our panelists for participating, and you've met Dana and Dr. Udall and Dr. Wray. So now let's briefly have some introductions from the other panelists. Can you each please tell me what organization you're affiliated with and how your organization is improving lives by addressing behavioral health challenges? Harpreet, why don't we start with you, and then we'll move to Corey and then Devin.
Hey, Heather, and thanks for having me on this panel. My name is Harpreet Singh Rai. I'm the CEO of a company called Oura Ring. We make a wearable ring. I know it's really tiny on the screen that attaches to your phone and gives you daily insights about your health, starting with your sleep, activity, and also readiness.
Awesome. And Corey?
Great. Heather, thanks so much for having me. My name is Corey McCann. I'm the Chief Executive Officer at a company that's called Pear Therapeutics. Pear designs, develops, and deploys products that are called prescription digital therapeutics, or PDTs. Very simply, these are software-based products that are designed to directly treat human disease. Our products go through an FDA review process. They get deployed broadly via clinician prescription. And in addition to really treating many of the conditions that we've been talking about thus far today, they create what is data transparency from the patient-reported outcome through to the clinician dashboard, through to even claims data. So thrilled to be here. Thank you.
Thanks. And now Devin.
Hi, everybody. I'm Devin McGraw. I was a co-founder of the Ciitizen platform, which is now part of Invitae. We have a platform that enables patients to get all of their health information from all the places where they've had care, that it's organized at their fingertips. So when they want to share it, whether it's with another family member, with another healthcare provider, or even contributing to research or all of those things, they have that information at their fingertips. Happy to be here. We are actually mostly in cancer and neurological disorders at this point, but actively moving towards the behavioral health space as well.
Okay, great. And Sonia is our amazing patient expert. Sonia, why don't you introduce yourself, and then we'll move to Adam and Garry. Sonia, you might be on mute.
Hello, everyone. Can you hear me now?
Yes.
Great. My name is Sonya Ebhotemen. I am a peer specialist at the Edward Junior VA Hospital here in Greater Chicagoland. And I am Also working with veterans to model what recovery looks like. I have a diagnosis of post-traumatic stress disorder resulting from military sexual trauma. And I am using my past experiences to develop and deliver services to the veterans I serve. And it's been a great ride so far. Part of my issues, I had many bouts of homelessness, single mom, many bouts of homelessness, suicide ideation, couldn't hold a job that would, help me actually take care of the family. And so coming to the VA, I actually went through a homeless department, I compensated work therapy department, trauma services and things like that until I could get back on my feet. And from there, I just made a promise to myself that if I ever started working for the VA, that I would, again, use my experiences to benefit the veterans that I serve. And that's what I've been doing so far. So far, I've been at 2 different VA hospitals, working as a peer specialist, and many other different areas from primary care to women's health to inpatient units and so forth.
Okay, great. And now Adam.
Hi, good morning, everybody. My name is Adam Haim. I'm from the NIMH, National Institute of Mental Health, and our mission is to transform the understanding and treatment of mental illness through basic and clinical research, paving the way for prevention, recovery, and ultimately cure. And the way we fulfill our mission is to support conducting research on mental illness and the underlying basic science of the brain and behavior. And we have a really robust digital mental health research portfolio, and we support research in this area through a variety of different funding announcements. We fund basic research, research on early intervention, all the way through large effectiveness clinical trials. And I'm really excited to talk about digital mental health research and our priority areas in this space.
Great. And then last but certainly not least, Garry.
Thanks, Heather, for having me. My name is Garry Choy. I'm a physician. I'm at UnitedHealth Group in the Office of Medical Affairs. I've had many years of practicing at the VA as a radiologist, and within UnitedHealth Group, I lead up our clinical technology and innovation group. So we look for innovations that we can improve how we can practice medicine to coverage to benefit design. So we have, as UnitedHealth Group, we have UnitedHealthcare and Optum as distinct business units, focusing, of course, on the payer side, but also on the services and technology side. And increasingly on the Optum side, we also have care delivery, which includes telemedicine and other ways of bringing healthcare into the home, like house calls, as well as remote patient monitoring. So very excited to be here today to talk about digital health and how we can better take care of veterans. And I think that applies to everyone.
Great, thank you. So the VA is the largest integrated healthcare system, and there is a huge opportunity for the VA to serve as a blueprint for how to successfully deploy digital health solutions at scale and to reimagine what safe, equitable, and ethical healthcare looks like. On a personal note, both of my parents are military veterans. My mother was an Army nurse. My father also served in the Army as well. So improving the lives of veterans really hits close to home for me. So just to kick off our discussion, let's start with Sonia, our patient expert. You're in the field supporting your fellow veterans, and you're working closely with patients. What are some of the current barriers that veterans face today when it comes to addressing behavioral health issues?
Well, the first barrier I want to talk about is stigma. There is stigma we know in society, but also internalized stigma. There are some cultures where, as was mentioned before, mental health is a taboo subject. And so making sure that we are hiring people like myself who have that experience in those different cultures that can be the face of hope for others, that's a barrier. And then the other barrier is, especially with this pandemic, we had to switch from face-to-face to virtual. And so VA did give out some iPads and tablets like that, but the problem was that there was only one particular software that was downloaded to those things. And so we have groups and WebEx, we have Zoom meetings as well that take place. And if a veteran had a VVC individual appointment, then they could no longer participate in those groups. And so with that, a lot of the support that they had when we were in face-to-face was missing. And then the flexibility of services received. Most of the services for veterans, especially with mental health, are from 8 to 4:30. And we know that things happen outside of those times. So being able to allow staff the flexibility to design programming that will benefit, and even if it's just the use of some of the digital platforms, like sending a motivational video or doing some type of encouragement and check-in at different times of the day versus just 8 to 4:30 is important. Making sure everything is culturally based according to the population that you serve. A lot of times, like mindfulness is a great EVP to evidence-based to put on, but depending on who you're delivering it to and how you're delivering it, it could be a barrier. For instance, someone who has experienced racism in the military and then come out into the VA, and the only guided imagery or the only mindfulness voices they hear are Caucasian white males, that presents a barrier for them to actually develop that. I was fortunate enough that when I started with my mental health journey, that I actually had a provider who saw the challenges I was facing when mindfulness came into play, and she actually took the time to curtail her programming to fit me so that I could still participate in the groups. I was not ashamed or given my own little silo, but she made sure that what she presented, that I had an avenue inside the group with all the other vets that I was there with to still participate. And that really worked for me.
All right, thank you so much for sharing your story and your insights. That was very insightful. So Harpreet and Corey, can you give us some examples of what's working? What are some of the successes with using digital health tools to address behavioral health issues?
Yeah, happy to kick it off. I think just building off what Sonia said, and again, Sonia, really appreciate you sharing that. I think, access is a big thing, right? I think, the way health is practiced today is more just a point in time. Yeah, health is daily, right? Minutely, secondly, every single second. So it's just, we don't practice it that way. I think, frankly, one of the successes we found for us is just the daily engagement. Being able to give users their data in our app, they're able to, start to ask themselves questions like, why is my data different today? Did I have something, let's say physically that I did yesterday? Did I overexert myself? Did I eat too much? Did I, drink too much? And see changes in their data day to day. And I think, some of the successes we found is that, when people were analyzing their data pretty early on during the pandemic, we had actually users reach out to us and say, hey, my data was off. My readiness score is off. We measure temperature, respiratory rate, heart rate, and heart rate variability as part of the readiness score. And some users early on were like, I saw my data, change significantly, but I didn't really feel that different. Were describing themselves as sort of asymptomatic or pre-symptomatic, I should say. Yet they decided to go get a test for COVID and found out that they were positive. I think that daily engagement and users telling us that story, honestly, is what led us to really work and pivot the company's research to focus on illness during the pandemic. And so, we ended up being the first wearable to partner with a research institution, UCSF, and we've now partnered with 2 more on producing studies that can show this phenomena. And I think a lot of businesses were able to utilize it, including soldiers. And so I think that's been a great success for us to hear. I think there's just an article in Military Times how there was a group going out to Afghanistan and was able to determine that they were sick before being deployed on that mission. So I definitely think, getting back to what Sonia said, that access, having the digital tools to engage daily, right? I think that allows people to see if something's wrong. And luckily, we've been able to show some research and develop some features around that.
Great. And Corey?
Happy to chime in here. And Heather, ironically, during a tech conference, I'm having a little bit of internet instability. And so if you can please just flag for me if my audio goes in and out, I'll turn off my video just to make it a bit more robust. I think like all of us here, we are deeply concerned about addressing both access and quality in healthcare. We want to do that to reduce overall healthcare costs, but we also want to do it to fundamentally better veterans' lives. I think we all acknowledge that there are major issues reaching homeless and remote veterans. And as I've heard acknowledged again and again and again this morning, there's really a dearth of highly trained therapists that can execute upon broad mental health, either via tele or face-to-face scenarios. And so really what we're doing at Pear is addressing these issues by building pieces of software that are direct treaters of human disease. As I mentioned a little bit briefly before, this is a new therapeutic modality that has become called PDTs, or prescription digital therapeutics. And I think much like what you are used to seeing for drugs, these are products that go through randomized clinical trials, they demonstrate safety and efficacy, they're evaluated by the FDA, and they're ultimately prescribed by clinicians. Really what's important here is that these are products that address both access and quality. And they do that by really completing the circle of data that goes from patient-reported outcomes through to clinician dashboards that clinicians actually use robustly in real time. And then we've been able to link back to claims data sets to really get that holy grail of data that goes from claims to outcomes to clinician-reported input to patient-reported input. And so maybe to make all of that a little bit more specific, we've got 3 products at Pear, which are currently FDA authorized. They're the first 3 products in the space. The first 2 address addiction conditions. Those products are called Reset and Reset-O. And across the 2 products, they are indicated to treat patients who are addicted to alcohol, cannabis, cocaine, and stimulants like methamphetamine. And then the Reset-O product is indicated for patients who are opiate dependent. Across what is a nationwide deployment, we've shown the ability for the products in the real world to be very heavily used, so daily use on the part of patients. We see our clinicians engaging about twice per prescribed patient per week with the Pear.MD clinician dashboard. And then what is really most heartening for me is that we see a dose-dependent relationship when it comes to keeping patients out of emergency departments, keeping patients out of inpatient hospitalizations, and you can then draw what are health economic numbers to demonstrate that these are not just products that enhance access. They're not just products that enhance quality. They do both of those things, but they're also products that save payers money. In this particular case, what would be the VA. And so that's really the opportunity that we see for the VA is a similar deployment, a similar broad deployment. And it's one where the minute a patient calls for an appointment, they get prescribed a PDT. And that's really a gateway into what is a blended care model where the PDT is the on-ramp prior to the patient receiving that remote but synchronous care via tele, or prior to the patient receiving care in a face-to-face setting.
Okay, great, thank you. So Sonia brought up issues of access and representation. So let's talk about digital inclusion and mental health equity. Dana and Adam, how do we ensure that digital mental health tools are within reach for all veterans and patients?
Happy to jump in on that. This is a topic that is so important. It's something that we talk an awful lot about at Headspace Health. And it's really about framing care in a way that is convenient, accessible, and culturally responsive. And I think Sonia teed this up so well in talking about matching and making sure that we're able to provide care in a way that is really resonant with somebody based on their demographic or their identity. But when I think of convenient, one of the things that sticks out for me is that over the pandemic, we have seen about a 50% increase in our overnight utilization. So a member will come on and talk to a coach. We have seen that spike by 50%. And what that means is that folks are not sleeping. They are up in the middle of the night. And we know that lack of sleep has profound consequences for physical health, mental health, emotional functioning overall. So we are thrilled that coaches are able to welcome people, able to work with them, provide skill building in the middle of the night. It's much better than doom scrolling or anything else that folks would be doing. But I think it speaks to the fact that care doesn't happen, needs don't happen between the hours of, let's say, 9 to 5. Folks really need to be able to access care at any time. I think also what's really important is to know the population. So when we're talking about veterans, for example, thinking about PTSD as being an incredibly common diagnosis, disproportionately so when we look at the general population, depression, the fact that the suicide rate is about 1.5 times that in the general population. It is really creating a service that is tailored for veterans and really takes these things into consideration. So making sure that there is trauma-informed care, that there is a coach available 24/7 in order to respond if somebody starts to have suicidal ideation. And this is a lot of what we're doing at Headspace Health, is making sure that we have those opportunities available. And then I think the third thing really is about equity, and it's making sure we're taking into consideration things like the social determinants of health. It's making sure that our team is trained in culturally competent care. We do trainings on a regular basis, and this could be on a specific population, as well as just what it means to be a culturally competent provider, which means knowing that we all come in with our own biases, our own worldview. How do we make sure that we really take that into consideration and provide interventions when we're working with a member that are consistent with their culture? So those things are incredibly important. We do a lot of training. It also has to do with making sure that our team is really reflective. So for our therapists, we are about 40% BIPOC. Coaches, we're about 45% BIPOC. So it's really important that when people come in, that they are seeing a provider that reflects them. And not everybody needs that, but we know that matching, for example, can really decrease dropout rates. People who feel heard and seen and understood in their cultural context are more likely to stay in care and have better outcomes as a result. Part of what we're also doing is offering care in Spanish, which I think is incredibly important, so that people can come in and talk in their native language and receive those services. So that's something we'll be building out as well. So I think it is all of those things, and it really is part of quality. So unless we're offering culturally responsive care, we're not offering high quality care. So in my mind, those things are really synonymous and a big part of what we need to focus on across the board when we think of solving the mental health crisis.
Great, thanks for those insights. And Adam, what are your thoughts on ensuring digital inclusion?
Right, it's a great question. I think Dana did a really nice job synthesizing the research in this area. So this is a priority area at NIMH, and promoting equity by continuing to build a valid evidence base to ensure effective treatment and care. So it requires an inclusive environment where members of racial, ethnic, sexual, and gender minority groups and individuals from lower SES status are represented in each phase of the research that we fund and in each phase of intervention development, from basic translational research to effectiveness research and service research studies. Also, individuals from underserved and underrepresented communities frequently experience reduced access, as we all know, to quality mental health service. So it's really important to examine, within the context of research, accessibility, engagement, and follow-up in a variety of different provider settings. And we know that one size doesn't fit all, and we know that we need to expand access and reach. And these are priority areas for the NIMH as well. We have a number of different funding announcements in these spaces. As we know, we need to do a better job to ensure that all of our mental health interventions, including digital mental health, which offers a lot of opportunity, but not equivalently to all individuals, to ensure that they're all usable for a broad array of individuals. And again, we have a number of different funding announcements in this area to support access and engagement and inclusion. And one of them that is quite relevant is focused on digital healthcare interventions to address the secondary health effects of COVID. And the purpose of this research is to focus on the role and impact of digital health interventions to do exactly what you're asking, to increase access and engagement and inclusion.
Great, thanks. Thanks for those insights. So we have these digital health tools, but we need, how are we going to pay for them? We need to be able to, providers need to get reimbursed. So, Garry, how do we define success with using digital health tools so we can structure appropriate payment?
Yeah, I think that others have said it as well, as how do we improve quality and therefore outcomes. And so I think when you think about payment, you think about healthcare in general, like whether it's a procedure or a visit. And Molly brought this up in her keynote too, that the question would be, would digital health be hybrid? And I think it would be, right? And one way is that there might be alternatives between the two, right? You could choose one or the other, and they might be equivalent, but they might need to go together. So when you think about payment too, you can look at it from the kind of logistics perspective. How do you fund the workforce? How do you actually get the technology and the people, the systems in place, the overhead required by the companies that are powering digital health, like all the great innovators here? There's a lot of cost associated with running a platform, with running a service. So how do you pay for all that? And I think it becomes really clear, the business model, if that there's a good value, right? You're getting actually lower cost, lower total cost of care over a lifetime. And you have to look at it, especially this is a new way of practicing medicine, so to speak. So is it episodic? Is it longitudinal? We probably have to look at it from multiple angles and look at modeling across time, across individuals and populations. And so I think when you think about structuring payment, I think we have to think about it from just a traditional sense, even before digital health. Ask the same questions. Is it worth the payment? Are you getting the ROI? And who gets paid? Is it the platform provider? Is it the physician or psychologist involved? So the professional fee. So there are multiple components to this. And I think the other thing that we should think about is data. I think, Adam might have mentioned this too, and Dana, claims data. Should we start to look at, other types of data? I know Harpreet mentioned it so well. You get secondly, data, right? So could we start to look at data to close the loop, to figure out, are we delivering value? And, at UnitedHealth Group, we have, so many great actuaries, healthcare economists, constantly looking at modeling how we intervene on how we care for patients. And digital health is something that people are looking at. We're on the lookout and constantly learning, what are some of the new innovations that we can bring to our populations who we serve. We want to serve them better with the latest innovations, but we want to make sure that we can afford it and afford to pay for all this for as many people as possible, to democratize access, Sonia mentioned too, how do we get culturally compatible care to as many people as possible? We want to look at all of these. So we want to look at special needs. We want to look at mental health, cancer, diabetes. And so there are many ways we can look at value too. It might be very content specific as well. So data really matters as we start to look at how we pay for all these great innovations. For example, Pear Therapeutics, Corey has done a lot of work. I think mental health is just the beginning for Corey's company. So it's a very exciting time. And I think we can all work together to try to figure out how can we pay for all this? How can we structure payments appropriately so as many people as possible have access to the latest tools?
Right. Okay. Great points. So you brought up the issue, the topic of data, claims data. So, kind of another aspect of this increased adoption of digital health and virtual care is we're seeing regulatory changes that are helping to open up patients' access to their own health records. So Devin, this is an area you know a lot about. You're kind of our expert on interoperability. What about the opportunities and the challenges of greater interoperability for veterans?
Great. Thanks for that question, Heather. The VA was actually pretty forward thinking with respect to getting patients access to data. They were one of the first to roll out a portal with the My Healthy Vet patient portal. But we're really where the federal initiatives are going is not just to give patients a view into all of their data, but to actually allow that data to be portable, allow the patients to have it, to use it as they need to use it, to share it in the ways that they want to share it. Whether that's with a family member, whether that's with another healthcare provider. And this is not to say that we need to become dependent on or ask for the veterans and their families to essentially be the port their data wherever it needs to go, right? I think ideally we have this interoperable system where regardless of where the vet is receiving care, their data is moving to where they are. It's all the data that's needed in order for them to get the most appropriate care. But we know that that's not necessarily happening, and we also don't necessarily want to leave the veteran out of that data conversation. The data really belongs to them, whether that's true from a legal standpoint or not. It is morally the right thing to do, is to allow them to have all the data about their care, including claims data, and then to be able to use that as they see fit. So that's, HIPAA has always given veterans and other patients the right to access all their health information. But where the federal government is going with respect to these newer interoperability rules, whether it's changes in certification rules for electronic medical record systems, or the so-called information blocking rules, which really put a thumb on the scale of sharing, including with the patient, like this is where the puck is going. And so in some respects, can be even more empowering to not have data as the obstacle, but data as actually the grease for the wheel that enables appropriate care to happen. And I think the last thing I'll mention is, in the mental health and behavioral health space, there are often additional laws that require the consent of the patient or the data subject before that data can be shared, in recognition of the stigma issues that Sonia brought up earlier. And in recognition that veterans and other patients will want to have a bit more control over that data. When the veteran has all of that data, they can share it as they see fit. And so some of the so-called obstacles that are in place around interoperability of some of the more sensitive aspects of this data are, can essentially it can help to resolve them when, in fact, the veteran has the control of the data and can grant access to it as they see fit.
Great, thank you, Devin. So unfortunately, there's just so many topics that I would love to tackle with this panel, but we are getting a little short on time. And I know that some of the other panels in this and later this morning and this afternoon are going to be tackling the topics of how you integrate all these tools into the clinical setting. So kind of just to give the audience kind of a view of looking ahead, let's talk about the concrete next steps to move forward. Sonia, why don't you kind of kick off this topic with, share your perspective on what can the VA do to make care better for veterans in this digital era? Sonia, I think you might be on mute if you're still with us.
Thank you. The first thing I want to mention is that, don't do anything for us without us. So along the way, as VA makes these changes and try to better care for veterans, make sure veterans are included in that. A lot of times we like to do what we want to do. I tend to say, when I was in mama and daddy's house, I did what mama and daddy told me what to do. I went to Uncle Sam's house, I did what he told me to do. Now we're grown and on our own. So let us have a say and let us take part and take ownership of what's happening in the VA. And then the other thing is, as we make these changes, ensure that not only veterans, but staff also have training and these different modalities, this digital stuff that's going on. We have to look at, when we went virtually, our population was a lot of older vets who had challenges when it comes to technology. So we have to provide the training. And then as VA put in all of this different software, some of the staff didn't know how to work the software as well. So make sure there's training, technology in that, and then again, just make sure that we are included.
Right, great. That is a really great point, Sonia. Thank you for sharing your perspective. Adam, what are your thoughts on, what are some next steps?
Right, it's a great question, and we often think at the NIMH, not where the puck is, but where it's going. And I'll give two examples of some promising research areas that we're really excited about. And when we think about developing research priorities, we strategize first about what are the gap areas, and then develop funding announcements behind those gap areas. And we see two pretty strong gap areas in regards to digital mental health research. So mental health interventions, like has been discussed, need to be flexible. One size does not fit all. So how do we develop interventions that can adapt to the needs of the user when the user has those needs? And a promising approach is called just-in-time adaptive interventions. And they use mobile devices and sensors to monitor individuals' behavior and then respond with tailored interventions at that moment. And these in-the-moment interventions target proximal, malleable behaviors and can really reduce the onset of more significant mental health issues. So we've released a concept that's been cleared, which alerts researchers that we have a lot of interest in this area. And we're really committed to doing more research in this space. And I know time is short, so just the second piece is really short. So while there are a whole number of promising digital mental health interventions in the research pipeline, we need to do a much better job about how to get them into the hands of the individuals that need them. So the pandemic has shown that telehealth can work for certain individuals. How do we sustain this? And an example is we have funding announcements which require investigators to leverage partnerships with digital health developers, some of whom are attending now, to use those well-established digital health platforms that have lots of users so that we can follow a deployment focused approach. In other words, at the end of the research project, we expect the intervention to almost be available to individuals at scale immediately. So that's another area of high priority for us, which will continue to allow more individuals to engage in this care.
Okay, great. And then to the other panelists, anyone else want to chime in and kind of briefly share your thoughts on next steps?
I think channeling Sonia's kind of don't do anything for us without us. I think, let's say, if you wanted to implement digital health for providers, I think one of the key things is to get providers involved, especially around digital health tools that are trusted, high quality work. They're simple, single click as possible, right? You just click on a button, something happens, like a digital therapeutic, or you're able to get somebody enrolled or referred into a platform. Because I think providers have a good sense and are trusted within the healthcare system, and they play a big, important role in the last mile. So a lot of times, a question we ask is, are we involving clinicians when we think about a program? And that's typically, that should be earlier in the conversation always, because you could actually get this to the patient as quickly as possible if you get the provider involved. So thanks, Sonia, for that. I also think that applies to providers.
Right, great point. So we're going to move on to the audience Q&A. We've gotten some really great questions from the audience. So first we're going to take, our first question is from Jennifer Liano.
Hi, thank you so much. I apologize, my webcam isn't working, but I was just wondering what type of solutions you have to help remedy some of the structural inequities facing digital health distribution. One of the studies I'm working on currently focuses on individuals with opioid use disorder. And one of the major challenges are very fundamental, such as access to cell phones and being able to pay for a regular cell phone plan. So what would you suggest we do as an industry, as a community, to help with that?
Well, I'm happy to jump in on this one, if that's okay. I think that when we talk about scaling solutions, it's easy to think about the sort of population benefit of that. But the other thing that is very real when we scale solutions is that it drives down cost. So if we can use AI, for example, or natural language processing, which is something that we use on Headspace Health a lot, to understand the need, that is a way of scaling care and allowing some folks to have access in a way that is much less expensive, much less time consuming. I think your question is a good one, which is, it sounds like it's about sort of if people don't have access to technology, to a cell phone, for example, what could they do? And this is where I think what Molly was talking about is so important, which is pairing in-person plus technology, because there is no one-size-fits-all solution. We know that there are folks who are less comfortable using a cell phone or who don't have access to it. And so I think creating, kind of building the pipes is the way that we like to talk about it, so that there is that integration where we're sharing information through technology with local providers providers is really key, because we know that there is no one solution for everyone, and that there are going to be certainly some veterans who are not as comfortable with or amenable to using digital health services. So there's also the need for in-person monitoring. Often if we're talking about substance use anyway, that is something we're thinking a lot about on the Headspace Health platform, is how to expand our reach there and partner with local agencies. So those are my kind of quick thoughts.
And Dana, if I can just really briefly just pile on there. I mean, we have a digital therapeutic that's deployed in 35 states for opiate use disorder. In some of those states, we address about 80% Medicaid patients. And so we're living exactly this question day in and day out. I think being backward compatible onto some of the most affordable phones that you probably wouldn't traditionally support as a consumer-focused app. So for example, making sure that you're absolutely bulletproof on the Obama phone, that's something that's really critical here. And then whoever asked the question is exactly right. When it comes to data access, that is a big issue for these patients. And so I think we should all be thinking about and building in data caching into our product so that these patients can go to a Starbucks and download a week's worth of content via the Wi-Fi there, and then come back for Wi-Fi again a week later. So these are all things, it's these little things that are critical to deployment here.
Great. Harpreet, do you have anything you'd like to add on this topic?
Sorry for the mute silence there. So I think, look, getting back to both points, I think that both panelists already just added in. The more value we can provide, I think, the more, we can show that, right, between us providers and, veterans as well, and the VA. I think then, you can see more funding in these areas, because, one of the things I think that's actually where we can be more innovative with the VAs, right? The VA, unlike, traditional employers and employees, right, has a much longer tenure, right, for the average person, right, that serves in the military. And so I think, as a result, actually, you have the ability for all of us here to take out even more cost, right, over time here. And so I think being able to actually prove that, any one of these sort of digital therapeutics can actually reduce cost, right? You're going to hold that cost for a greater amount of time, I think can actually lead to, even the VA realizing, right, that we need to issue phones, we need to issue more tablets, like Sonia was saying, because we're actually seeing a reduction in cost. So the investment is worth it. So I think, the onus is on all of us to work together, to prove that out. And then hopefully we can get more access and equity there. And so I think, that's one of the things that I think we've been thinking about, how we can prove that and come up with use cases that do reduce costs that significantly, and then hopefully work, with everyone to roll that out.
Okay, great, thank you. Great points. Next question is from, and I hope I'm pronouncing your name correctly, Pear. You had a question for Garry at UnitedHealth. You can take yourself off mute and ask the question yourself if you want.
Hi, sorry, I was on mute apparently. First of all, I work at a digital health startup myself. So for Garry, kind of my question would have been, how does a digital health startup get in touch with an organization like yourselves so that you can actually evaluate, whether or not we could provide the types of benefits to your customers that you're looking for in terms of that return on investment and then the patient outcomes that you mentioned earlier. And a second question to Corey as well, in terms of the solutions that you provide. How do you work with hospitals and doctors to ultimately get your solutions prescribed to the patients that you can actually deliver the outcomes to the patients that you are looking for?
Yeah, thanks for your question. So before United, I was in multiple startup ventures prior to joining. And so it can seem daunting, but also at the same time, we're constantly building as well as looking for partners. And so feel free to reach out to really any business line, whether it's a business leader or clinical leader or other. You could feel free to reach out to me. We're constantly on the lookout for innovations that make a clinical difference, that help our patients. And of course, we need to make sure there's a business model, that it fits within the business as well, so product market fit. But happy to evaluate any startup. We're constantly looking for things that, perhaps we haven't thought of, that there might be a complementary need, that there's a strong engineering team, a strong platform, and that there's traction, things that have traction in the market with employers. Employers are starting to look at it because our customers are the same customers. We serve numerous large accounts. Employers provide a lot of the healthcare within this country, and even government programs like the VA. So if the VA is looking for something, and how could we better serve our VA patients? So I think look for synergies, look for the opportunity to really help a payer like a United, and there are many payers out there, and also many of the folks here, like everyone here might have already an existing relationship with a payer. Perhaps there's a partnership that you could also join up on with another industry organization or company. Dime, who is sponsoring this great forum, is also an organization that certainly has the network that early stage venture companies can ride off of in order to find their way and make a lot of impact within the payer space. But I'll turn it over to Corey. I think your second question is for Corey here.
Thank you, Garry.
I think the top line for me is that the burden of evidence falls on the manufacturer. And I think the more evidence you have, the more empowered your position, be it with payers, be it with clinicians. When I think about our interactions with clinicians, really it is a discussion about clinical data first. So I think the expectation is that these are products that demonstrate solid clinical data in randomized clinical trials. I think there's an expectation that the products are safe and effective and have been evaluated by a third party like the US FDA. And so then we very quickly get to questions of deployment. And that's where we continue to add back-end features, EMR integration, but essentially every prescriber wants to do this as quickly as they can possibly deploy. And anything that feels kludgy is going to be an impediment to them deploying at scale. So that's sort of the second thing that we're always looking for. And then the third box that every prescriber is looking to check is around economics. So how can they get reimbursed for their interaction with the back-end dashboards? How does this ultimately generate to an ROI in their practice? Does this allow them to see more patients more quickly? Really, what is the health economic argument for the prescriber? And I think if you can check all three of those boxes and you can do it in a robust way with reams and reams of data, then I think the world is really hungry for these types of solutions.
Great, thanks. So one last question from Michael and the audience, who wants to know how to make these tools self-sustainable. So I'd like to ask each panelist to kind of give a rapid fire 30-second answer to this question, which is, who will foot the bill for those who are outside of the VHA healthcare system? Dana, would you like to tackle that first?
Sure. Well, some of the good news on our side is that we've recently got reimbursement. Cigna has agreed to pay for coaching. That is a huge benefit because coaching has traditionally not been reimbursed within the healthcare system. You've had to have a diagnosis, which again leads to the fact that most people are not getting care until they get a diagnosis. So I think that the idea that payers are going to be potentially paying or covering services that are not traditionally covered is going to be a huge boon. The other thing about self-sustaining, I think from a member perspective, is really making it engaging, making sure that members feel really comfortable. So really designing a user experience for them so that they keep coming back, coupled with payment to really support that long-term engagement and use for the various populations. That was another question I saw come through. That's very important too, that we're not just looking at sort of aggregate data, but making sure that for all different groups, they're able to stay engaged and have the outcomes that we're looking for across the board.
Great. And Harpreet, your thoughts?
Yeah, look, I think building on what Dana said, right, the more evidence, and Corey too, right, the more evidence that we can show, I think the more, pockets of money that you'll see flowing into the system. I definitely think at the end of the day, though, you have to really go, as Sonia said, right, don't design anything for us without us, right? And I think that can go for any aspect of health, right, in any person. So ultimately, even if you're getting served through a system, whatever that system may be, it comes back to engagement and usability with the user. And I think that's honestly where probably a lot of the system, didn't really think about some of the inconveniences before that went into place, and it's no one's fault. But I think we have new technology that make these things more accessible. If we can prove the results, I think people are going to want to invest in it, regardless of if they're in certain systems or not.
Okay, now Devin, your thoughts?
Yeah, I mean, I would just agree with everything that's been said, but just to underscore that the paying for this should not be the responsibility of the veteran.
Right. So, and then Adam, your thoughts?
Right, this is a great question, and I provide technical assistance to many folks in small business who want to apply to the NIMH Small Business Research Grants. And the big question is, who's going to pay for this and why? A lot of people come to us with great ideas, and then we ask that question, there's crickets. So we expect that question to be embedded into the research. So if you're going to be going down the software as a medical device route, that you engage with FDA and say, what evidence do you need to get this authorized? Or also, if you think about, the overall value, what is CMS going to need to see in order to make the determination that to add a CPT code for this? And how do we provide that evidence? So the expectation is when we fund research in this area, that question is probably the most important one, because developing interventions in isolation that work really well in the lab is useless if people can't have access to them.
Right. And Dr. Ray, you'd like to share your thoughts?
Yeah, I mean, totally agree with the implementation and dissemination piece, right? It's if this clinical intervention works, that's great. How do we actually get it in the field? How do we push it forward? And then the other piece that I would add to the comments already made is just that unfortunately in behavioral health care, we don't put enough focus on prevention. And I think that prevention is the word that's really underscored all of what we've talked about today, but really not explicitly said as much. So just wanted to point out that we really need to make this a focus of research and implementation, because we don't want people getting to the point where they need to come to the emergency department for a mental health crisis. We want to catch this way downstream. And I think digital health is really going to help us immensely with this. So prevention, 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 please. and I'll sign off with that. Thank you, Heather.
Okay, thank you. And then Garry or Corey, any last thoughts you'd like to share?
Maybe I'll build off of prevention. I think prevention has a good business case. And I think also a good clinical case, because as clinicians who want to intervene earlier, you'll be able to make a difference. And I think since we're talking about digital health, I feel digital health essentially is enabling a more connected healthcare system. Because we're more connected, we should be able to intervene earlier. And so the business case should be there. And so the question is, Adam mentioned too, we also see a lot of innovations. There's so much supply now of solutions. The question is why? Why would we pay for something? And I think prevention, as Jen pointed out, is a really, I think a very practical and a very high value case. If we can intervene earlier, the business case is there and the clinical case is there.
Right. And Corey, any last thoughts?
Yeah, I think whether it comes to prevention or digital health solutions, I think the question shouldn't be how can we afford to pay for this? The question should be how can we afford not to pay for this? So, when I look at all of these different digital health implementations, it is all about pricing products less than near-term health economic savings, such that you're generating a health economic benefit every time the product is used. And for payers who are not providing coverage, they are leaving cash on the table. That's the model. I think every payer is going to set exactly the parameters that they want to see. But I think all companies in the space should be happy to go at risk if your product works, and then hash it out on the back end and do an at-risk deal.
Great, thank you. So Dr. Ray and Sonia, thank you so much for sharing your insights. And especially Sonia, thanks for sharing your personal stories and insights as a patient and a peer support advocate. And thank you to all our panelists for joining this really insightful conversation. I wish we had another hour to kind of dig into these issues. But with that, I will turn it back over to Jennifer.
Heather, absolutely fantastic panel. Harpreet, Devin, Garry, Adam, Corey, Sonia, Dana, Jen, we are spoiled by your insights today. And I think the pieces that I appreciated the most were sort of how you teased out some of the elements of Molly's talk, right? We're looking at a hybrid future. We can use these sort of digital tools not to replace the clinician, but to augment them, to bring them to places and at times and in a way that is most accessible to all of the people who need sort of clinical care. Sonia, the language you gave us around sort of, you know, nothing about us without us, whether that's the patients we're all here to serve, whether that's the clinicians we're actively trying to support. This is critically important as we go forward. And then a sort of rigorous evidence base, whether that's for sort of clinical effectiveness, whether that's for equity, or whether that's for sort of health economic benefit. This panel touched on an extraordinary sort of a wealth of information that we will take forward, and I'm incredibly grateful for all of you and those of you on the line engaging in the conversation. Thank you.